Everyone, and welcome back. This lecture is going to be discussing some models of recreational therapy. I'm not going to lie, models can be a little bit intimidating, especially when you start seeing kind of the flow charts and the structure of some of them. But if you do dive deeper into the models, you really are able to see that they really do provide foundation for clinical practice. We're going to be talking about two recreation therapy specific models, and then we're also going to talk about a third one, the leisure ability model, which can apply to, I would say, a lot of different disciplines, whether you're rec therapy, rehab, or even some other, scientific clinical fields. I will say that it's more of a not such a concrete concept. I know that learning about models both in undergrad and in grad school, and the deeper you get into them, it can seem really complicated and overwhelming. But again, like I said, I really do think that they provide a good foundation and overview of what we're trying to accomplish in our practice while we're working with our different client groups and populations. So we're going to go ahead and dive into that. As always, if you want to discuss anything more or think about how a model might apply to your specific population you're working with, or either now or in the future, feel free to reach out and kind of just be thinking about things in the back of your mind as we're going through these about how you might be able to apply these different models to potential practice in the future. So as I mentioned, the first model is going to be rec therapy specific. So the first model we're talking about is the Comprehensive Recreational Therapy Service Delivery Model, or the CRTSD. This is a holistic, systematic model, which is really going to guide RC practice. It provides continuity of care. It's looking at all the way from intake to discharge. And it's also going to ensure individualized, goal-oriented, evidence-based, and outcome-focused care. So as we can kind of see, this is revolving a lot around the APIDE, the Therapeutic Recreation Assessment Process, which, as we recall, are assessment, planning, implementation, evaluation, and or discharge and transition planning. So this is really related to that. All right. So when we're looking at, the consumer with a health condition, that's our overall person that we're going to be looking at, as you can see in the model. That's kind of our assessment process. You're going to want to identify the strengths, needs, barriers, and interests of that particular client and collect baseline data. You're going to want to use those standardized tools, such as the functional independence model, or the FACES scale, or things like that. And you're going to want to establish foundation for treatment goals. Again, and then to your planning, you're going to look at developing an individualized treatment plan and collaborating with the interdisciplinary team, setting those SMART goals, and really aligning with the broader healthcare community to reach those outcomes. So we're really going to understand the client. Again, the assessment of the specific behaviors and emotional areas, medical review, interviews are super important. We want to maintain those comprehensive and specific goals. Have an activity and task analysis. That's when your ICF is going to come into play. And then you're really going to want to look at those interventions, which are going to lead to those improved outcomes, accountability, and evidence, and production of case studies, possibly in the contribution to evidence of TR practice. So it's kind of a full scale. Like I said, everything that you're doing is going to relate to working with your individual participant, and also thinking about how we can take that information, relay it to other practitioners to help them in what they're practicing. Some benefits of the model are that it ensures client-centered care. It's going to promote that evidence-based practice, and it's also going to support the continuity across treatment settings. It's also important that we use models in general across the board because they're going to enhance a professional accountability and recognition. So research, and to kind of get us in line with those other professions. Before we move on to the next model, I just wanted to give a brief example. This one's kind of based off of my research of a military family retreat and kind of what it would look like. So following API, the assessment would be identifying a family communication strengths and weaknesses. Planning, we're going to set goals for the stress reduction and improved connection. The implementation is going to be family leisure education and different group activities. And evaluation, I use the FACES or the Family Communication Scale, pre and post tests, or the FCS. And the discharge is going to be, we're going to link the families to community programs to continue support. So, and then we can take those studies, study those outcomes, and relate it back to our practice. Again, this model is really comprehensive. It's cyclical and structured, as you can see. It has a lot of components, but it's going to ensure the quality, accountability, and meaningful outcomes for our patients. It's a core framework of our professional practice, so definitely one to keep kind of in your back pocket as you're going through your practice. So the next is going to be the Therapeutic Recreation Service Model, or the TRSM. This model has two major roles. So one is the intervention and leisure experience. So for example, in a hospital, an intervention might be a structured social skills group, and the leisure experience might be a guided music session for stress release. So there's a lot of importance of informed consent and client partnerships, especially when it comes to this model. And clients really need to be a part of the process, and they should either agree to understand this process. So again, this is going to walk through some main points with some examples that are relevant to our clinical or community practice. Keeping in the back of your mind as we go through this model, how you would apply this concept to your own field work or your clients. So that's a common theme throughout. Important to relate it back. So the TRSM was developed by Peterson and Stumbo in 2000. It's a framework that really explains the scope of recreation therapy services. It focuses on progression from illness to disability and looking at creating optimal health and well-being outcomes. And like we mentioned before, it emphasizes the clinical rehabilitation and community wellness and leisure goals. So this is kind of encompassing both sides. I think in this model truly encompasses what rec therapists are doing. We're looking at that rehab side and working with other people, and then also having them get out into the community and really exposing them to those wellness and leisure goals that they might have. So some key assumptions that we can look at when related to this model are that illness and disability impact the whole person. Recreation and leisure can improve health, functioning, and quality of life, and clients can move along a continuum of service towards independence and optimal wellness. And again, that's essentially what this whole diagram right here is looking at. So we have our nature of service, our leisure experience, and our nature of the therapeutic recreation provider and the client interaction. So we want to make sure that the client makes those rational choices and is self-sufficient and independent. So the first section that we can see, the diagnosis and needs assessment. So there are 4 components of the model. So diagnosis and needs assessment, the treatment, rehabilitation, education, and prevention and health promotion, as we can see up at the top. So looking at the diagnosis and needs assessment, that's when we're going to want to identify problems, strengths, and needs. We're going to want to establish a baseline for functioning and use assessments, interviews, observations, and standardized tools. So that's in that first preliminary phase. With treatment and rehabilitation, we're going to look at improving functional abilities. So that can be either a physical, cognitive, emotional, or social. We're going to look at reducing or eliminating any barriers to participation, and we're going to offer that clinical perspective interventions to our clients or patients. With education, that's when we're going to teach our leisure skills. So that's when our leisure skills or leisure education is really going to come into play, whether that's related to decision making or coping or problem solving. That's when we're going to tie this piece into our implementation in our practice. We're going to also build a knowledge of leisure resources and opportunities. So again, if that's somebody with a physical disability, how do they access that once played basketball? How do they access recreation therapy programs that are, adaptive sports programming? How do they find, if they can no longer drive, how do they find public transportation? All of those sorts of things are all in that education piece. We're also going to emphasize self-management and independence. So how can they get back to a new baseline and a new normal for themselves? Next is prevention and health promotion. So that's when we're going to want to encourage the long-term wellness and quality of life. We're going to promote healthy leisure lifestyles and support stress management, resilience, and that community participation. So the model structure, it's a continuum. So as we can see, we have our rectangle, and then we have all of our arrows continuing across the umbrella. The services are going to range from highly structured treatment to self-directed treatment, and that's more of that health promotion piece. The client can enter at different points depending on their needs. So they can enter into kind of this cycle depending upon where they're at in their rehab. So the goals are to restore or rehabilitate impaired functioning, educate clients for leisure independence, and to promote lifelong wellness and optimal health. We're going to want to support holistic growth, physical, emotional, cognitive, and spiritual. So whatever that looks like to us. So again, going along our continuum, the applications and practice that we can talk about in hospitals in our rehab setting, that's when you're going to focus on treatment and rehabilitation. In community programs, that's when we're going to emphasize our education and health promotion. And then, for example, going back to my research, military families and or maybe even older adults, this can be integrated use of all 4 components. So looking across the spectrum of what we're going to be doing. So intervention, leisure experience, all of those things. So some of the benefits, it's going to provide a comprehensive service framework. It's going to ensure the continuity of care from clinical to community settings, and it's going to strengthen the rec therapist's role as a healthcare and wellness professional. So again, you're kind of wearing both hats. It promotes accountability and measurable outcomes as well. So that is our model. So next, a little bit more of a broad model, the leisure ability model, or you might hear it referred to as the LAM. So again, this is another model that is pretty common in practice. It was developed by Peterson and Gunn in 1984, and it was expanded upon by Stumbo and Peterson in 2004. So the expanded model isn't extremely old. It is one of the most widely recognized TR models, so you may or may not have heard about it before. It's very common to use in research, and it's a frequently used and studied model. This model is going to focus on helping individuals to develop a satisfying, independent lifestyle and it's on the idea that leisure is a basic human need and right. So obviously that is something that recreation therapists firmly root their values in. So again, you can see kind of how this model really relates to and helps rec therapy in practice. So we have some more diagrams. We can say that some key assumptions about the leisure ability model are that leisure contributes to a quality of life and wellness. Individuals may experience barriers such as illness, disability, social, environmental barriers that limit their leisure involvement. So the recreation therapy's role is to reduce those barriers, to build skills, and support independence in leisure. So there's three main components of the leisure ability model, as you can see in the diagram. So functional intervention is the first one. So that is improving physical, cognitive, emotional, and social functioning. We're going to address deficits that interfere with leisure participation, and we're going to want to prescribe activities that are therapist directed. So we can see that our degree of control and our degree of freedom and participation, that's what we're going for here. So looking at leisure education as a second component of the leisure ability model, that's when we're going to teach knowledge, skills, and attitudes for leisure education. So these might include leisure awareness, so different assessments on values assessments, attitudes, maybe even take a personality test, that sort of thing. Social interaction skills we're also going to look at, and leisure activity skills such as sports, arts, and games, and resource awareness. So again, those community opportunities, accessibility, all of that encompasses that leisure activity and resource awareness section. Really the goal of this is to empower clients to make independent leisure choices. And the last component is that recreation participation. So actual engagement in recreation and leisure experiences. We're going to provide opportunities for practice, enjoyment, and social interaction. The therapist's role in the recreation participation component it can be a variety of different things. It can either be a facilitator, so you yourself are facilitating a certain activity. You can be the organizer, so you're going out and organizing something for that individual to participate in. Or you can be a supporter rather than a director. So that could be even, your client's participating in now a adaptive sports program, and you're there just to support and provide any input that, that coach may need or something like that if it's a new activity for them. Examples of this are community outings, different hobby groups, and adaptive sports, as I just mentioned. So as we can see, again, the flow of the model, it moves from being therapist-directed to client-centered. The clients may enter at any level depending upon the needs, so much like the other models that we talked about. The overarching goal is independence and a leisure lifestyle. The goals are to restore functional ability where needed. We're going to develop leisure-related knowledge and skills, promote independent and satisfying leisure lifestyle, and enhance overall quality of life and wellness. So some ways that we might apply the leisure ability model to practice. In a rehab setting, we might look at look at it as a functional intervention to help rebuild lost skills. In a mental health setting, we might use leisure education for coping, stress relief, and social skills, so finding a variety of things to help with that. Community programs, the recreation participation is going to be developed to maintain wellness and community connection. So providing programs that are going to enhance the needs of the community. And an example with veterans or older adults, you can use it across all three for resilience, social connection, and long-term wellness. So some strengths of the leisure ability model: it is a simple, clear, and widely applicable model. Again, and this will, I'm sure you'll see it many more times in your studies. It focuses on that client independence. It is recognized by the NCTRC and other professional recreation therapy standards, and it is very adaptable across a diverse population of settings. So the last model we're going to talk about is the therapeutic recreation service outcome model. So here, much like the other ones, we can just see that there's different functional domains. There are the cognitive, psychological, physical, spiritual, social, and then leisure. And we can see how we have our functional capacity and independence, our wellness, health status on the x-axis, and we're going to just see how that goes over time. And this last slide kind of made a little model just comparing them so that you can see how the different models connect and intersect and differ. So we have the leisure ability model, and then all of our other models here. We're going to really see that the focuses are, how the focus has changed. So we have our independent leisure lifestyle, our focus process of delivery for the CSDM, the TRSM is the scope of services and treatment, and that's how it's related to wellness, and then the TROSM, which is the focus of client outcomes. So we can kind of see how the top two are service scope and lifestyle, and the bottom two are process and outcome. They're focused on client outcomes and how they're related. So that just gives a little visual. Again, like I said, I know it's a lot of information, and it can be complicated to kind of keep everything straight within all the models. If you're interested in learning more about models, there is a lot of research if you want to look at a model related to a specific population. So thanks for hanging in there with me today. I'm here if you have any questions, and thanks so much. I'll see you guys next time. Bye.